about the, that everybody will be muted and all that.
Yes, sir. Very good evening to all of you to this meeting of the Kerala Federation of Obstetrics and Gynecology, co-hosted with UNICEF. The topic again, this is the in our series of COVID-19, the third wave. We thought that keeping the current scenario in mind, it will be appropriate to take up the topics of vaccination in pregnancy and obstetric implications of the third wave in today's meeting for the benefit of our members. I request Ajit sir to please give the introductory address. Before that, I request only the moderators and the experts to unmute themselves. All the others, please keep yourself mute. If you have any questions to ask, please put it in the chat box, and I assure you that our moderators and PAILY sir is also coordinating the session. The questions will be picked up from the chat box, and your questions will be duly answered. None of the questions will go unanswered. So please mute yourself, everybody. And I request Ajit sir to give the words of introduction. Ajit sir, over to you.
Good evening, all. Respected seniors, dear friends, experts, moderators. I acknowledge the presence of Dr. KAUSHIK, the representative of UNICEF here. Actually, it's a COVID-19 series we are doing every Wednesday. Now, today, we are going to discuss about two important aspects: the vaccination in pregnancy. Again, there are a lot of doubts. We will take up the questions. And another thing is the implications of third wave in pregnancy. We have seen the change, what happened in the second wave, about the implications in the pregnancy. We had actually a lot of maternal death compared to the first wave. So is there an entity like third wave, and how it is going to affect the pregnancy, that we are going to discuss. And we have very good experts here. Dr. Rajeev, Dr. Indu PS, and Dr. Sandeep. And to moderate the session, we have Dr. SAREENA GILVAZ, Dr. LEKSHMIAMMAL, and Dr. JYOTHI CHANDRAN. And I thank over to Dr. Venu for the proceedings.
Thank you, Ajit sir. We have a very impressive lineup of experts here today. PAILY sir has taken, and along with Ajit sir, both of them have taken a lot of trouble in compiling this expert panel group. I request PAILY sir to take over the session and provide a brief introduction regarding our experts of the day. PAILY sir, over to you.
Thank you, Venu. I think we will quickly proceed to the subject to be addressed. But before that, let me introduce our experts who have kindly consented to be here to elaborately tell us about the various questions that we may have. First of all, let me introduce Dr. Gagandeep Kang. Unfortunately, she will be able to join us only a little later, as she is part of an advisory group for Government of India, and they have a meeting going on currently. So she may join us by about 8 o'clock. She is the professor of virology attached to the gastroenterology department. And my knowledge about that department goes back to the time when Professor Mathan was the head there, and they have done the pioneering work on rotavirus. And you may probably know that this Professor Kang also has rotavirus as an interest, and she is working in that line. That is when COVID struck us, and she is one of the advisors to Government of India on that. The second expert we have to comment on is Dr. Rajeev Jayadevan. I don't know how to introduce him, whether to introduce him, because he's now every day on the TV, and his curriculum, if you look at it, is so impressive. He's a product of CMC Vellore for undergraduate and post-graduation, then moved on to UK and then US and back to Kerala. Now at the moment working at Sunrise Hospital, Cochin. But I think he spends more time educating the public and the profession rather than treating the patient, because he is a much sought after speaker for the media as well as for the profession. So thank you, Rajeev, for agreeing to be with us. And his interests are actually very wide, a lot of them on public health as well. So very much grateful to him for joining us. And the third expert we have is Professor Indu. Earlier, when she was chatting with, I think, her own counterparts in the medical colleges, she was saying she is in Tricur now. When we look at her address, it is in Trivandrum. Now she is in Tricur, and she said it is on transfer that she is in Tricur. But a very much sought after person to talk about these aspects about vaccination in Kerala. And it's actually Dr. Rajeev who asked me to contact her and see that she's also part of the panel, because as all of us know, community medicine is the specialty where things are focused. And Indu also is advising government of Kerala on various aspects related to COVID. These experts, and to ask them our questions, we have three other experts. And SAREENA GILVAZ, I don't think needs any introduction to the obstetric and gynae crowd of South India or even India. She is professor at Jubilee Mission Medical College, Tricur. The second person is LEKSHMIAMMAL from Trivandrum. She is attached to the SUT Hospital and Medical Teaching in the National Board there. But more than that, she is the live wire of KFOG as related to MDNMSR. What that stands for is maternal death and near miss surveillance and response, a new find of Kerala Federation, and she is the state coordinator for that. Then we have the dynamic JYOTHI from Calicut, professor, and also the president of the Calicut Society. But more than that, she's there, be it for dance, be it for academics, in everything that she touches, she is excellent in that. So we have these people to guide us through the common questions that are likely to come up. But let me just start off. One more person is there. He has kindly agreed to be with us, and that is Dr. Sandeep K. Sandeep is so busy these days because he is put in charge of the overseeing the vaccination drive in Kerala by the government of Kerala. By position, he is the deputy director. I don't know whether he has been promoted further beyond that, but our association with Sandeep had been going back to quite a few years because he is the bridge between the Kerala Federation and the health department of the Kerala government, because he helps us with the confidential review of maternal deaths, periodic review. And by training, he's an anesthesiologist, but I don't think he has given anesthesia to anybody in the last so many years. He had been always with public health. And thank you, Sandeep, for agreeing to be with us. So with this, let us start on. I'm sure all of you will be waiting to ask questions. And some of the questions we could think of, we have added here, but there may be others, supplementary ones coming up. As and when they pop up, we will try to accommodate them. But first of all, let me request Indu just to tell us just an outline of the various vaccines that are available, the different types of them, and what are the principles behind them. Could I request you to do that, Indu? And after the housekeeping, let me just also say that even though we have the three experts assigned some questions, you can always overlap. If there are some deficiencies to fill in, but somebody else is answering, you are welcome. Okay, Rajeev. Yes, please, Indu.
Thank you, sir. First of all, I salute the Kerala Federation of Obstetrics and Gynecology for the kind of work they put in, not only in COVID times, but even prior to, as Madam was, PAILY sir was mentioning the maternal death and near miss audit. If all the several specialties have their own associations, but I think Indian Academy of Pediatrics and Obstetrics and Gynecologists Federation are the two pillars which are really into system, right? Building the system, and that way, prior to vaccination, these kinds of interactions and the so may I share a slide?
Yeah, Venu, we could allow share slide.
Enable, yeah.
Listen.
Kana.
Sure. We can.
This is the epidemiology part of it. I'll come to the vaccines. I think since Dr. Kang is there, she's the real pillar and the vaccinology expert. And of course, Dr. Rajeev will also deal with the recent researchers. And Sandeep is also there to deal with how the program is being implemented in Kerala. Regarding the third wave and the antenatal women, what are the probabilities? This is the global scenario now, and what is seen in the southeast, in the lilac, that violet color is the Southeast Asia region. As we can see, the initial big drives, the surges were in the Americas and in Europe, and now we can see when India contributed by April, May, and to an extent now June by end, the cases are coming down. Though we say it's coming down, it's not exactly really low, because as we can see, the African region sees a hike of nearly 34% of cases and 42% increase in deaths. And Southeast Asia, overall, there is a reduction, but last week there is a minor increase, a 12% increase in the number of cases that's reported from India. All other regions, the cases are coming down, and Europe has an increase of around 10%. If you go by the number of cases, India still stands at the second position in the number of new cases contributed to the global burden. And compared to the previous week, there is a 12% increase, which is something we have to note. I'm sure Dr. Kang will discuss more on the Delta variant and how the vaccines. But in general, we have the four variants of concern: alpha, beta, gamma, delta, of which the alpha is the one which has come from UK, beta from South Africa, gamma from Brazil, and the delta, which became a variant of concern in just May 2021. I think by today, some 95 countries are reporting delta. So that is the speed with which delta virus spreads, and that is the speed with which the second surge saw such a wide, very high secondary attack rate, which involved antenatal women. As we know, in epidemiology, when we have a vulnerable cohort, there's always a probability that they get infected. For example, Elizabeth Madam is also there. All of us know childhood vaccination. When children became more, when the proportion of children who got vaccinated with those, vaccine preventable, vaccines against VPDs got increased, then there was a shift of these diseases towards more vulnerable cohort. For example, measles among youngsters, medical students. It happened in Europe, it happened in Kerala, everywhere it happens. So similarly, the antenatal women in Kerala, I think US and all, the situation is different. If we, in US, they have a system in which they report, the pregnant women can report to the CDC, that registry. I think nearly 126,000 women, pregnant women, have already reported. They looked at the outcome, the newborn, the antenatal complications like pregnancies, induced hypertension, diabetes, and other complications during the antenatal period. So that is the data which is available from US, though they say the risk is, they explain the risk, benefit, and then women were given the option, and then the data comes not from in the form of a trial, because none of the trials included antenatal women. But since in these countries women have already received the vaccine, that is the data that is available. I think it's quite a large number, larger than the sample size of any randomized control trial. And it is really the Delta that is driving the current pandemic. It has driven the pandemic in India, the second surge in India, and it continues to be. And as we know, Kerala, there's a pattern. There is every district, a subset of samples are sent to the CSIR IGB for genomic sequencing. So a pattern of these genomic variants, which are circulating in our districts is available. So there initially it was alpha. We also had beta and all, but later we have been sending samples from November 2020 onwards. So as it evolved, Delta has replaced the other predominant strains, and this is happening all over the world. And this is the global picture. We can see India, for that matter, many of those countries having all the 4 variants of concern. The effective reproduction number, that's the epidemiology part of it, it is much higher than the alpha. So Delta, in every other country, that is the pattern that you see, outcompetes other variants and becomes the dominant strain. And that is expected also. This is the Indian, and we are the discussion point is that, will there be a third surge?
Yeah, we were planning to come to that later in the discussion, Indu, but if you could just complete that also.
I'll complete it. Okay. So the difference between the Indian wave and the Kerala wave is that the Indian wave was rather steep to go up and steep to come down. It's just like a wave, a tsunami. The cases go up. So that pattern in epidemic curve, the mortality will be really high and the health system strain will be huge. And here the Kerala pattern is a little different. The attack rate, the positivity rate continues to be at 10%. And if you're talking, I think I'll skip these slides and come back to these at a later stage. Just as an introduction, if you would like to prevent a surge, I think vaccination is the most important intervention. Kerala, I think if you consider the entire population, some 30% of the population has been vaccinated, but this excludes 2 major groups, our children and, adolescents up to 18 years of age, and the antenatal women. So they continue to be vulnerable, and actually when such outbreaks occur, the vulnerable are at a high risk. And this is above 18 years, it becomes 40% for 2 doses and 12%, 40 for single dose and 12% for 1. And the other methods, I think, it's generic. If we have to protect our antenatal women, it's general, right? If the community and testing, of course. This is really important because when an unlocking happens, it's both for the individual patient and for the society. Otherwise, they'll not know how these sparks begin, and all the other measures have to continue. I just had one point in relation to the contraception because these are COVID times, and probably this discussion point will come later. I think I'll stop sharing.
Thank you, Indu. We were hoping to come to the third wave a little later, but now that you have introduced it and explained that, thank you for that. But can I focus at the first part, because that is everybody is so keen on. Can I ask Rajeev about the different types of vaccines available, as well as the principles on which they are based, just briefly?
Yes, thank you for inviting. I know it's a short session, so I'll go straight to the topic.
Yeah.
As we know, the majority of vaccines in India have so far been Covishield, and a minority have received Covaxin, and now Sputnik is here, and Moderna will be in very shortly, and a few others will come in. But regardless of the vaccine use, we now know that vaccines, they do a couple of things, just to put matters into perspective. Vaccines, either they stop you from getting the virus, and if you get the virus, they stop you from getting sick or dying. So these are 2 separate entities. Unfortunately, when we read media articles and when we read half-baked journal articles, people get confused between the 2. The 2 are completely different entities. I mean, you can't even compare the 2. I'll just dwell on that aspect first, because I think that's, even though I'm into academics, I'm also a communicator, and I think it's important we communicate this well with our patients. See, vaccines in general, if they generate neutralizing antibodies, they will stop the virus from attaching to the cell. But neutralizing antibodies do not last very long. We know that in the body, it's a plasmablast that actually produce these neutralizing antibodies. So soon after vaccination, you get a very high percentage of plasmablasts in our cell, and they don't last for more than a few weeks. So your antibody count will come down. In fact, at 6 months, it will be 50%. And at 1 year, it will be 30%. So that's a given for any infection, forget COVID. So during this time, you are expected to get what is called breakthrough infection. Whether we like it or not, that's the way it's going to be. When we are vaccinated, we buy a little bit of protection against infection, but you're not 100% protected. I'll give you the status from India because I worked very hard to get the data out of sources that are sometimes unpublished. So across the board in India, I'm talking from a healthcare worker standpoint. After vaccination, I've gone through around 280 cases of breakthrough infection, thereabouts, 218 cases. There's a publication on that. The survival is 99.6%, which means that out of the 218 who got breakthrough infection, 99.6% survived. That's good. Now the question is, if you take 100 people who are vaccinated, how many will get a breakthrough infection? That unfortunately is not good news because through India's second wave, we have 2 to 12% of people fully vaccinated getting infected. And that is not good news to me because that amounts to substantial morbidity to the healthcare community. Agreed that healthcare community is exposed to high viral loads around the clock in closed rooms where we don't have much ventilation options, but that is a fact. But the good side of the coin is that these people are not dying and very few of them required admission to hospital. There's a large series from CMC Vellore, my own alma mater, that's around, they've looked at around 9,000 of their own employees that were vaccinated with Covishield, mostly Covishield, and they have a 92% reduction in hospitalization, which is probably the best data we'll get in India. So Dr. PAILY asked me about vaccines in India. This is the ground reality that I'm giving you. This is the reality about vaccines in India. Now, what we do not know is how long the protection against severe disease will last. As I mentioned at the beginning, vaccines protect against a fence. It's almost like imagine a house and you build a fence around it. You try to keep the thief out. The fence gets weaker with time and the thief is able to get inside our property. But the problem is, the more important issue is whether the thief actually breaks into our house or not. And that is called serious disease or death. Now, we believe that all the vaccines are excellent at preventing the second aspect. The thief can do whatever they want in the premises. He can wander around my lawn or my garden, but he may not do anything to me or my family. So that is the way we should approach data that comes out of vaccines. It is important that 2 doses are taken, particularly for the inactivated vaccine. We know that a single dose of the Covishield has a substantial amount of protection. In fact, it's surprisingly good. And just yesterday, you might have seen some of my Twitter. If you're interested in science, my Twitter is just my name, Rajeev Jayadevan. You'll see around 6,000 plus tweets on pure science. No, there's no nonsense on it. Pure science on all the papers that are being published every day. So you might have seen my paper from my tweet from yesterday on a paper that just came out of England, Public Health England. In fact, it is from not from Public Health England. It's from another group in England. Basically, what they did was they looked at an extended gap between vaccines, and this is breakthrough information. This is cutting-edge technology, cutting-edge research. They looked at how people behave after an extra-wide gap, says 1 to 10 months. What if you space them out for 10 months? So, very good results. Very excellent, high levels of antibodies, and they didn't really measure too much of T cells. So those are some cutting-edge information. They also looked at what is called a third third dose. Remember, in India, most of, I'll say 95% of them have received, of us have received Covishield. So we need to know if we need a booster. I don't believe so. But what we do know is if we get a booster, it actually works. See, the problem with Covishield is, or Johnson & Johnson is, they're all living virus vaccines. They're not live virus vaccines, but these viruses are alive. The question is, if we get a booster dose, will we become immune to the vaccine itself? See, it's a virus, so our body may throw out the virus. But this trial has just shown, has erased that concern, that if you take a third dose, it actually works. But this is by no means to endorse a third dose. We do not require a booster just as yet. There's no evidence that anyone requires a booster as of now. But if it's needed, we can safely take it. So that is the latest research that I can give you. Back to you, Dr. PAILY.
Thank you, Rajeev. Can I just ask for a clarification? You said that there is about 12%, 2 to 12% of those vaccinated can get infected. Does it apply to only Covishield or Covaxin and all that, or does it apply to the Pfizer? Because Pfizer seems to claim 99% protection.
Yeah, I know. I don't know about that. See, what I gave you is on-the-ground data from multiple institutions in India. So the lowest is in fact below 1%, and the highest is 12%. So the truth lies between, let's say, 0.5 and 12% over a severe wave. Remember, the second wave that hit India is at least 6 times as powerful as the first wave is. How do I know that? Just divide the total number of cases by time taken. So it's at least 6 times as powerful. And healthcare workers did take a hit, and doctors died as well. We don't know. We don't have a breakdown of how many doctors died after getting fully vaccinated. We believe that number is actually quite small. But to answer your question again, it is this is what the wave left behind. If you take 100 people who got vaccinated, 0.5 to 12%, you can expect them to be infected through a wave, and that's a reality which we need to face as we go forward with our practice.
Thank you, Rajeev. And meanwhile, we have got Dr. Gagandeep Kang with us. Welcome, Dr. Kang. We introduced you already and explained to everybody why you are not with us in the beginning of the program. But thank you very much for joining promptly at 8 o'clock, that, as you said. Welcome. And can I request JYOTHI to carry on with questions if you have any?
Yes, sir. At the onset, I welcome the experts, and I'm happy to be part of this endeavor. So I would like to ask Dr. Sandeep that do we have to take any special consent before giving the vaccine, and what does the content of the consent should be?
You're talking about vaccine in pregnancy, isn't it?
Yes.
Because other ones, we don't need a special consent.
Yeah. Vaccine in pregnancy.
Sandeep, if you can unmute. Yeah. If you can. Venu, if you can unmute Dr. Sandeep. Venu?
Yeah. That is about the pregnancy, isn't it?
Yes,
Yeah. We are especially addressing the pregnancy situation now.
But the presently, madam, there is no communication from the government of India received so far regarding the immunization of the pregnant mothers.
No special consent is required because...
No, not concerned, sir. What I am saying is that we have not received any communication to start vaccination on pregnant mothers.
Dr. Kang, do you have anything to add on to that? Are we allowed to vaccinate the pregnant as of now or not?
Yes, we are now finally allowed to vaccinate pregnant women. This was just announced by the Ministry of Health, and perhaps communications have not yet come to the states, but at least for some states, I know that the letters saying vaccination of pregnant women can start have been received. Now, the issue here is, do you need to take a special consent of pregnant women when you want to offer them vaccination? I think there is no requirement in the guidance for a special consent, but there is a requirement for a special explanation. The information needs to be communicated to pregnant women that these vaccines have not yet been evaluated in clinical trials. Some trials are ongoing, but women have been receiving these vaccines, including the ones that are available in India or equivalent vaccines, in multiple countries around the world. And these vaccines have been found to not have any safety issues in pregnant women, and in fact are beneficial. There is guidance in 17 countries. India is now the 18th country to add pregnant women into their priority lists. And there are 57 countries that have conditional recommendations for vaccination of pregnant women, saying women who are at high risk because of their profession or because of comorbidities during pregnancy should be offered vaccines. So there are totally over 70 countries that are over 80 countries that have recommendations for pregnant women, and India is one of them now. There are ongoing discussions at WHO right now, which are around, should we be making pregnant women into a priority population? So not just saying it's okay to vaccinate pregnant women, but actually advancing that to say we have a duty to make sure that we vaccinate pregnant women. In other countries, they don't have an all adults vaccination strategy. But even there, they are thinking about, if we have an elderly vaccination strategy or above 45 vaccination strategy, then pregnant women should be treated as a younger population with something like comorbidities that requires them to be prioritized for vaccination. The issue is also being raised of what if a pregnancy occurs in a woman less than 18 years of age? What should be done as a recommendation for that? For that, I think it's very unlikely we will have a formal recommendation, but certainly 18 and above, any pregnant woman can be vaccinated now.
Any trimester?
Any trimester. So this was also discussed, whether the first trimester should be avoided. And in discussions, it's been decided that any trimester is fine. Mostly women are not going to know that they are pregnant very early in their pregnancy, but any trimester is accepted as being fine. The reason for deciding to do that is that with shortages of vaccines, you're not sure that you'll be able to access the pregnant woman again and again. The discussion with other states, so I've been part of the discussions with Tamil Nadu, and we've been thinking about whether you should try to combine this with the tetanus immunization, 2 doses, or give it separately. And the general discussion is, because the vaccines are in short supply, just give the vaccine whenever you can. And later on, when vaccines are no longer in short supply, we can think about, if a pregnant woman needs to be vaccinated, then give it along with the tetanus vaccines.
We will come to that, the interval between the other vaccines in a later time. Thank you, Dr. Kang. And LEKSHMIAMMAL, would you like to ask anything to Sandeep?
Dr. PAILY, can I add a comment to that?
Yeah, please. Yeah.
Yeah, you said it's an informal session, so we'll add a couple of comments. So one is, as Dr. Kang said, she talked about comorbidity, and there is a growing consensus that if you look at the various comorbidities that actually cause death, not being vaccinated is the biggest comorbidity now. You know, comorbidity is a condition that you have that increases your chance of dying, or increases your chance of getting really sick. But not being vaccinated is a huge comorbidity, and I think we should really convey that idea to the population. Back to you.
Hello.
Yeah, Dr. PAILY, back to you.
Yeah, thank you, Rajeev. And if I may ask Sandeep, what's the current policy of government of Kerala regarding vaccination during pregnancy? You said that there is no guidance from the government of India.
Yes,
but
sir.
can we, working in Kerala, can we recommend vaccination to our pregnant women?
Sir, for all vaccination, for all COVID vaccination, we are following the Government of India guidelines. Because we are not giving any other priority group or any other group added to the vaccination. The pregnant, lactation.
Sandeep, if I may just intervene, Sandeep, I think your light is from behind you, so people
can
see your face well.
Unfortunately, my light is below.
Okay, that's all right. Please carry on.
Yes, sir. Sir, we are following strictly. We are strictly following the Ministry of Health and Family Welfare guideline. So far, they are not allowed, or we are not received any communication regarding the pregnancy vaccination.
So, as you heard, probably Dr. Kang
few weeks back, we received a communication regarding the vaccination during lactation. Then we started that one. If we received a communication, we will immediately start the vaccination of the pregnant woman.
And then only we can say whether they really require a registration also prior to that, or they can just walk in and get it. Sir, what we understand is different districts have different policies. In practice, some of them do allow them just to take it after taking a consent from the vaccinee, that is the pregnant woman, that they won't blame the government for any adverse effects like that. At least some of the doctors, what we do is we just close the eyes and say, it's up to you, risk is yours. But if you are a close relative of mine, I would certainly recommend it. That is the way we now get over the problem at the moment. Okay. Lakshmi, would you like to ask anything more to? I think Lakshmi is.
Sir, one thing to add, sir, that registration, on-site spot registration as well as the other one, that pre-registration, both are present, sir. But in the most of the district, due to the shortage of vaccine, we are allowing only that pre-registration or taking the allotment and then come to the hospital. But as per the Government of India guideline, we can put both spot registration as well as the registration through COVID.
Now, as a representative of the government, can we just request you or ask you one point? I know that there is shortage of vaccine, but considering the vulnerability of the pregnant women, can we have a policy that they get priority on this?
Yes, sir. Sir, definitely, sir. If Government of India permit or Government of India communicate that we have to provide vaccines.
As you heard from Dr. Kang, that's only a matter of postal delay.
Yes,
soon it will come to Government of Kerala. So in that case, at that time, will we be able to get a priority to the pregnant women because the vulnerability is so much more?
Sir, definitely, sir. We can give a spot registration for pregnant women. There is no problem.
Okay.
Or if they are coming for antenatal checkup, we can give the vaccination also along with that checkup.
Okay. SAREENA, would you like to ask anything to?
Yeah. Dr. Sandeep, I just wanted to ask you, so would you be giving these vaccinations through private hospitals? Or should they necessarily go to a government setup to get the vaccine? If and when you...
Yes, sir. It is not unmuted. So presently there is two ways. One is the Government of India free supply of vaccine. It come to our 3 regional vaccine stores, and we are providing it only through the government COVID vaccination centers. It includes almost all institutions in the government sector. Another is on the private sector. Private sector, they can, it's a complicated process. They can send a request to Government of India, then and pay the money to Government of India. Then Government of India will forward that request to the Serum Institute or concerned vaccine manufacturers, and they will release the vaccine. That in short, the private hospital can buy vaccine from the vaccine manufacturers and provide to the patients.
Okay, PAILY sir, can I just mention one point? It's just a discussion point.
Yeah.
Now that it's very clear that I think we were expecting that orders to come. The government system was like that, orders to come once the decision was taken. Every day, like till evening, I was just asking Vinu, has the order come and all. Okay, anyway, let's hope within 1 or 2 days, everything will be in place and we'll start vaccinating. In that case, it's really important, especially in Kerala, though we say the CDC and all will say you weigh the risk and benefit. So in that case, I'm sure there will be a lot of queries and discussions in the media among the general public, antenatal, and the gynecologists and obstetricians are going to be the ambassadors who have to clear it. I think as Sangeeta was mentioning in the chat, it's important that we tell science, disseminate, as 1, 2, 3, Dr. Kang, what would you like as the major discussion points that can go to the antenatal women in India? Because CDC and all, we have all those data, and I think they have looked at 3 categories of adverse events, and that is the data available. So that way, relevant for Kerala, what would be the major risk side? I'm talking about the risk side. Then they'll, of course, benefit. We have lots of other points to the.
Before Dr. Kang answers, let me request one thing. All your faculty as well as the experts, don't mute yourself in between, because then you cannot unmute on your own. You may need Venu's help. So you please keep unmuted throughout. Okay, please, Dr. Kang.
So I think in terms of the risks, what needs to be communicated to pregnant women is the fact that when we think about pregnancy and vaccination, the vaccines that we currently have are equivalent to inactivated vaccines. While we might not have a lot of evidence that was generated in carefully followed up women in clinical trials, we have a history of using inactivated or inactivated equivalent vaccines in pregnancy for a very, very long time. And there have been no additional safety issues. So I think that is important to emphasize. There are data available, not necessarily with the classes of vaccines that we are currently using, but data on equivalent, in a way, vaccines that deliver message and therefore require the host to produce protein. Those have been used, and there are data available now on over 100,000 pregnant women with outcomes that show that there is no increase in risk and evidence of benefit. So in general, there are no safety issues with these vaccines. One of the questions that always comes up is that in pregnancy, what should we be thinking about in terms of thrombosis and thrombocytopenia syndrome? And is this a special worry in pregnant women? There is data so far only on 3 pregnancies. I'm on the Global Advisory Committee for Vaccine Safety, and we've been reviewing the data on TTS, and we have confirmed evidence of 3 pregnant women who had TTS after vaccination. And this is out of tens of thousands of pregnant women who have been vaccinated. So I think the general consensus is that pregnancy does not increase your risk of TTS.
Thank you. Thank you, Dr. Kang. Is JYOTHI unmuted, or are you muted, JYOTHI?
Yes, sir.
Okay, if you could, would you like to ask?
Yes, sir. Dr. Kang had mentioned that there is no contraindication in first trimester also. But is there any evidence to suggest such teratogenicity?
So this is, as I mentioned, this was something that has been debated and discussed for a while. And even with the ACIP discussions that happened, it was when it was first recommended for healthcare workers, and then later more broadly, the discussion was around, should we restrict for not giving during the first trimester? So the decision was not to restrict. So among the women that have 100,000, so initially when the data came out for 35,000 women and then for 90,000 women, the bulk of the outcomes were in women who had been vaccinated during the second and third trimesters, because the ones who were vaccinated in the first trimester had not yet had an outcome. But now we also have women who were vaccinated in the first trimester for whom we have outcomes, and there's nothing different.
Dr. Kang,
May I just add to Dr. JYOTHI's question? Just add it. I think the three categories of adverse events, the ACIP, the Advisory Committee on Immunization Practices, categorized one was pregnancy outcomes, miscarriage, stillbirth, etc. Third is pregnancy complications, the pregnancy-induced hypertension, diabetes, etc. And the third is the newborn kind of thing. And I think with 126,000, I think as on June 21st, that is the data that they gave. These are the outcomes. And I think Sangeeta in between had a question in relation to Kang's explanation. The TTS data is in relation to Covishield. I think the data is in relation to AstraZeneca, the Oxford AstraZeneca.
Yes, it is.
And that is Covishield.
Yes. So among the cases in pregnant women, there's one from India in a healthcare worker, one from Brazil, and one from another country that I don't remember.
Dr. Kang, can I just ask you a question since you're at it? You were telling us that any vaccination in India could be taken by the pregnant woman, right? But we were told that Covaxin is an inactivated vaccine, and so that is preferred over Covishield. Have you got anything to opine on that?
I don't agree.
Okay.
I know that people say that the adenovirus vector is a live virus. Well,
Yeah.
you know, our virus is live at any time. They are either capable of replicating or not capable of replicating. And the adenovirus vectors that we are using for the Covishield vaccine is actually a non-replicating vector. It's been engineered to be unable to multiply. That's why I think that it is considered equivalent to an inactivated vaccine.
But I can see Dr. Rajeev pull up his hand. Dr. Rajeev,
yeah,
any
you know, I was going to say exactly what Dr. Kang said, so I'll pass on that. And I call it a virus with a vasectomy. You know, so this is a virus who's just had a vasectomy, so it can't make kids. So that's one way to explain to the public. And the other difficulty that as doctors we will have when we communicate this is people always focus on rare outcomes. Say, for example, they'll say, we heard it produces clots. And, you know, people read in WhatsApp. So you know, I think we should fundamentally understand that the human mind is mathematically challenged. You know, no matter how many marks you got in high school, we are all mathematically challenged. And the larger a number gets, actually our ability, jokes apart, the ability of the human mind to comprehend numbers past 500 is actually quite limited. We may think we are very smart, but we are not. And the bigger the number gets, our ability to discern differences between, let's say, 100,000 and 200,000, it is not very good. Our mind is not very good at that. And you add numeracy, the challenges of numeracy to it, it gets really worse. My point is, you can explain with metaphors. You can say, listen, we hear about train accidents, but does anyone have a problem traveling in trains? No. Yeah, it's pretty much like that. You know, these things are very rare outcomes. And to put things in context, I put in a very, very scary figure, which very few people in India are aware of. Our maternal mortality rate, I say the amount of risk that the Indian woman takes to bear a child is 1 in 1,000. She's signing a document, you know, whatever document, she has to sign the document that I'm willing to take a risk of death 1 in 1,000 times. You know, that deserves a lot of respect. That's one. And second, where is the risk of 100,000, 1 in 100,000 clots? Where does that even compare with this risk that this poor woman is taking? So we want to reduce her risk of dying by vaccination. I think if we try to get too technical with common people who don't understand medical terminology, we may make it worse. So these are some tools that you could perhaps use.
Dr. Kang, I've got just one question to Dr. Kang. You said you used a huge number of 100,000 women, pregnant women have no increased risk. Is it our Indian statistics or is it the United States?
This is global. In India, we don't have a similar pregnancy.
I have a related question, Kang. The next set of questions, the queries our obstetricians are going to face is that, in that case, which vaccine is better?
Yeah,
we had a discussion on Covaxin. So next they'll ask, is it Pfizer or Moderna? Moderna already some initiation has come. So is the mRNA vaccine? Is it the human adenovirus? Because Sputnik has adeno 5 and adeno 26. We mentioned about Covishield. So that is better. Which is better? Which one
Let's
will
not
have
get
least,
our hopes
yeah.
up. Okay, the Moderna vaccine that is coming to India is a donation from the US. It is not commercial supply. CIPLA is only facilitating the import of the vaccine and the regulatory process for getting it approved. We are not going to have this vaccine available to us for the next several months. So right now, our choices are Covishield, Covaxin, and maybe Sputnik.
So does it apply to Pfizer also?
So right now, all vaccines can be used in pregnant women.
No, what I meant was, you said Moderna we will not get for a few months.
Commercial supplies. So the discussions with Pfizer are ongoing. Pfizer, unlike Moderna, Moderna is a company that didn't have a product till they had the COVID vaccine. Unlike them, Pfizer is a company that has a strong presence in India. So Pfizer doesn't need CIPLA. Moderna needed CIPLA to do the running around for them. Pfizer India will be responsible for their own regulatory approvals, is working on that now. And they will be the ones who will import the doses of vaccine when they are available. But whatever it is, both Pfizer and Moderna are going to have a trickle of doses at best. There's not going to be hundreds of millions of doses of these vaccines appearing on our shores anytime soon.
Is it because of the keeping conditions, the very low temperature that is required to keep it?
No. In fact, now Pfizer's temperature requirement has been changed. It's the same as Moderna's.
Okay.
So
1 month, yeah.
Yeah.
Lakshmi, would you like to ask anything?
Sir,
I want to ask Dr. Kang one very practical question. Many people patients, they keep asking us, they are planning to get pregnant. They are going on thinking of getting pregnancy. So can they get vaccinated now? That's one question. Second question is, they have missed their periods, and then can we get vaccinated now, or should we wait for the first 3 months to get over? Because in Kerala, they are also conscious about the first 3 months and the teratogenicity. So should we, if there is a choice, should we avoid recommending vaccination either preconceptionally or during the first 3 months? Or we can say, no, go ahead.
Preconception, they can just go ahead. I mean, there is I think FOGSI has a checklist that can be used, but really there isn't any issue to say that preconception, you shouldn't get vaccinated. Again, if they've missed their period, there is no evidence to say that you should delay vaccination by 3 months. Obviously, if you're not going to force anyone to get vaccinated. So if they want to wait for 3 months, you can have a discussion with them and say, if you'd like to come back, then come back. But during the time from when they visit you and when their 3 months are up, it's very important to emphasize that they need to make sure that they are protecting themselves from infection.
Thank you, Dr. Kang.
In the US,
you wanted to ask
in the
something?
US, they made a very specific recommendation that the woman does not have to wait for the second dose to become pregnant. So she could go ahead with her life in general. It doesn't, in fact, she doesn't have to match her lifestyle, whatever she does in life, or whatever plans she makes in life along with the vaccination schedule. So they made it that simple. So I think that answers the question as well. So in other words, if a woman has got only 1 dose, she can go ahead and get her pregnancy done, and then get pregnant, and then get the second dose after that. And as Dr. Kang correctly said earlier on, there's really no problem with another vaccine being given even within 2 weeks. There's no problem with that.
Something which both of you answered, let me just re-emphasize. This is a concern coming in the chat box as well about the Covishield and the thrombogenic potential of that. Rajiv already addressed that in very good examples, but can we just say that because of the reports of the clotting, increased clotting in some countries where they have specifically, I think it was Switzerland, which said that, they don't want to use the British Covishield and all that. Do we have to make any distinction between these different brands when you recommend in pregnancy? Rajeev,
Definitely not. Definitely not. These are extremely rare events, and the decisions that countries make, it's their business. The way we see it here or across the world, this particular vaccine is used in so many different countries, and the risk of an adverse outcome happening is so tiny, which is why I said the human mind is difficulty perceiving this. And the mortality, if it happens, is it's still not too bad, in the sense it's got about 30%, 1 out of 3. Those patients don't do very well. So I'm talking about the real bad clots, the CVSTs, the real cortical venous sinus thrombosis. Those ones, if they get, I think the mortality earlier on was around 1 out of 3. They have changed. That's with treatment. So it's 1 in about 100,000. There's really no need to be concerned. But the problem is the human mind never thinks rationally. We always have this emotional connect with, oh, this nation has banned this vaccine, so there must be something wrong with it. So I think we should really get that out of our heads.
In that context, if I could ask you, is there any difference between the Covishield that we produce in India by Serum Institute and the one that they make in Oxford? Because I understood that the technology was the same and they transferred it here, but now the European Union and Britain doesn't allow or give credit for Covishield taken from India.
Well, the world listens to Dr. Kang. We'll hear her words about it.
The problem really is that what is made in India, it is an identical product to what is made by AstraZeneca. The problem is that the brand names are different. So the AstraZeneca product is the Vaxzevria, and the product in India is Covishield. Covishield has not applied to the EU or any EU country for licensure. As soon as it applies, it has all the data to get that approval, but it had not applied. It should have applied in January when the EU was discussing the Green Pass program. It didn't apply then.
Lakshmi, would you like to ask anything more to Dr. Kang?
Again, another practical problem. See, we give tetanus toxoid, maybe another influenza shot. So should there be an interval between these and the COVID vaccination?
We follow the standard, standard practice. All vaccines can be given at the same visit.
Can I bring in Dr.
Different
Sandeep
sites, right, ma'am?
One thing to add, sir.
So
at
sorry.
different sites, isn't it? You can't take it to the same site, different sites. I think that should
One
be
thing to add.
Yeah.
Sir,
Yes, Rajeev.
Yeah, Dr. Sandeep, can I ask you, this issue about Covishield, which was just mentioned here, there is an option to change the name on the certificate into AstraZeneca. Now, can you tell us about that? You can go to COVID app and request the name to be changed from Covishield. So if you want to travel internationally and so on, can you brief us about that?
Yes, sir. Sir, presently that we are getting certificate from downloading from the COVID application of Government of India. It contains the name as name of the vaccine as a Covishield and Covaxin. But there is another option, the Kerala government site, that is covid19.kerala.gov.in. On that site, we can register and get a vaccination certificate. We have to upload the other vaccination certificate and details. That is downloaded from the CoWIN, and then you will get a certificate which states that it is Covishield and it is AstraZeneca. As well as there is a subscription. There is a note below that it is saying that this AstraZeneca and Covishield are the same vaccine with the different names.
So will that solve the problem of the international travelers?
Sir, we are giving it to all international. Those who are booking for that Kerala government certificate, we are providing it through the eHealth Kerala site.
Lakshmi, would you like to add any more questions?
Again, before taking the vaccine, pregnancy, should we be doing some tests like they are more prone to thrombocytopenia, thrombosis and things like that? So should they be taking some tests before they take the vaccine?
No, because TTS is completely idiosyncratic. There is nothing that predicts it. There are people who have thrombocytopenia for a number of reasons, And even that does not predict that they will develop TTS. So there is no need for testing. The most important thing is to be able to recognize the symptoms if anything happens. And this is very rare.
Jyoti, can I?
I had a doubt, ma'am, like supposing patients of renal transplant is there, and it was mentioned in the chat box, patient on methotrexate or patient on anticoagulant. So do we need a special concern for them, a special consent or change of medication?
So for people who are on methotrexate, the American College of Rheumatologists recommends not giving the dose of methotrexate for the week following vaccination. The other immunosuppression, we have to be aware that people who are immunosuppressed for any reason are not going to respond well to vaccination, particularly people who have been transplanted. There are approaches now that have been tried out. This was published recently, that if you give transplanted patients an mRNA vaccine, if they haven't responded previously, about 50% of them will respond with one booster dose. So maybe with this, so what I've been telling people is that if we are getting doses of Moderna, we should be keeping it for an immunocompromised population and thinking about giving them boosters, because that would be probably the best use of a small number of doses.
Do you include pregnant women because they are also partially immunocompromised in that group?
Well, actually, studies have been done looking at immune responses of women vaccinated during pregnancy, and there is no decrease in their ability to respond to vaccines.
Lakshmi, would you like to add anything? Any further questions?
Early discussions were going on, but is there any reason why we should prefer mRNA over the other mRNA vaccines over the other ones?
I think the only thing that we can think about is when we think about safety issues, all vaccines have safety issues. With mRNA vaccines, we now have this new issue of myocarditis, especially in younger people, which is a bit of a problem because, you know, in younger people, your risk of severe disease or mortality is very, very low, and equals now the risk of your developing myocarditis when you have when you get vaccinated. And we know that myocarditis does kill people. So you do have to weigh benefits and risks of vaccination. Same thing for AstraZeneca. We are seeing this risk of the TTS syndrome. We had the recent report of GBS, unusual presentations of GBS. That is still under investigation. I think we need a little more data on that to try and understand what the issues are. But in general, there is no question that benefits outweigh risks by orders of magnitude. So getting vaccinated is the best thing you can do for yourself and do for your family during pregnancy or at any other time.
Let me pitch in a little bit on the Guillain-Barré syndrome. You might have seen the publication from Cochin about 7 cases of Guillain-Barré syndrome, all of which occurred within 14 days after the first dose of AstraZeneca vaccine. The peculiarity of Guillain-Barré syndrome with the vaccination is, when I say with vaccination, it is just, you know, linked with vaccination. There was a high incidence of bifacial paresis and also multiple cranial nerves involved. And in the Kerala series, 6 out of 7 required ventilation, but nobody died. They all recovered gradually to some extent or the other. But as I said, you know, these are just very, very, very rare events. But when they occur immediately following vaccination, they do get immediately linked with the vaccine. But this similar experience has occurred there was another series, I believe it was from UK. I could not be sure. There was a similar series from the UK, which was almost identical. So there is definitely a risk, like with any vaccine, because, after all, vaccines induce antibodies, and you could have antibodies against or immune response against your nervous system. So that's bad luck. But the good thing is Guillain-Barrés do well with treatment. So again, there's really no need to be worried about that. Most of them occurred after the first dose.
Can I ask you, if we take the vaccine to know whether it has been effective, especially as a healthcare worker, do you suggest to check for the antibodies that we develop? Is it possible?
Yeah, let me take that question too. I'll take that question. All right. So this is a problem. This is a problem. We are having commercial labs do antibody tests to people, and it's creating so much of confusion in the community, particularly among healthcare community, because everybody wants to do something and then show it on Facebook or on WhatsApp and say, look, these are my antibody levels. And then everybody who sees it wants to do the same. And then somebody will go and check it, and they'll find titers nil, and they'll panic, and they'll call Dr. Kang and say, Dr. Kang, please, my titers are 0. What do I do? The point here is, I'll take 2 minutes to explain why it works like that. See, among all the antibodies we produce, the neutralizing antibodies are a very, very small fraction. None of the commercially available tests measure these neutralizing antibodies. They only measure total antibodies. That can be total RBD, they can be total spike, total nucleocapsid. It doesn't matter. But among those neutralizing antibodies, which are basically antibodies that go and bind into certain parts of the virus, they are called neutralizing antibodies. Bottom line is, we can't measure neutralizing antibodies in a commercial lab. So there's no point in trying to measure it. The point is, if you have a very high value, yes, you can say perhaps there was either a response to vaccination or from past infection. The problem comes when the result is negative. How do you interpret that? When you have a low result, or it can be either because it's below the detection limit of the kit, or it may be a very low neutralizing antibody titer. But that does not mean that you're not going to respond when you get the infection. Your memory cells are going to recharge immediately into plasmablast, and they're going to shoot out the antibodies that you need. So it creates a lot of unnecessary anxiety. So we discourage people from routinely checking antibody levels in the labs after vaccination.
Thank you.
PAILY, sir, may I just add to that? Actually, this is a very common question. Probably with the antenatal vaccination also, this might come up. So I think one of the common explanations can be, not only for COVID vaccines, there are multiple drivers or pillars in immunology. One is cytotoxic T cells, neutralizing antibodies, even the T helper cells. And finally, there is an immunologic memory where the bone marrow plasma cells matter. So many of these recent studies, I think the 3 major studies, one from, Rockefeller, Washington University, and there are a set of German researchers. I think all these 3 papers appeared in Nature. And they showed that the long term, I think long term means still 1 year we have. So that is similar to the kind of response that we have for other vaccines. So it is rather a story which is revolving not just around the antibodies. There are several other mechanisms through which the immune memory works, not only in COVID vaccines, but vaccines in general. Yes. So we not be really worried about the antibody. Not only that, I think these vaccines, I think I'll just continue Rajeev's discussion on whether we require a booster or not. I think some of these studies, we don't know what is going to happen with the Delta Plus and all. But otherwise, I think infection, the vaccine, infection plus vaccine, I think these combinations, I think, just like other communicable disease would have much more to contribute to long-term memory. I think these are all positive, positive notes from the vaccine side, but then the Delta Plus, I think the efficacy data is yet to be.
There's a note from Dr. Elizabeth Jacob that FIGO statement says Tdap bar influenza vaccine to be deferred for 14 days after COVID vaccination. So should we wait, Dr. Kang? Any?
Yeah, so I think they had put out that statement, and then we had a discussion at WHO about whether this needed to be done for the products that are currently available, and decided against it.
Now that vaccination has been allowed during lactation, much before when it comes for pregnancy, is there any protection to the baby from the antibodies that are developed?
So if we look at antibodies that are transferred, they can be transferred transplacentally during pregnancy or in breast milk during lactation. In breast milk, the antibodies that are transferred can protect in multiple ways. The most important is coating the upper part of the oropharynx, where you may see some amount of virus and get protection from illness. We know that the gut is also a site where the virus can replicate. So these antibodies can protect the gut, but they do not offer systemic protection. There has been some discussion around whether you might wind up having antibodies that are in the gut cross the epithelial barrier of the gut. I don't think that that is very likely. It's been seen in some animal models, particularly mice, where you get IgG uptake in neonatal mice. But I don't think it is a mechanism that has been shown in humans.
There's a
Dr. Kang, I
question
think
to
there was
you.
earlier also a question on, I think, Dr. Uma, whether antenatal vaccination will increase the risk of MISC.
Yes, I answered that in the
Okay,
chat.
okay,
Indu.
okay, that's fine. Okay,
Yeah,
that's
there's
fine.
no evidence of that.
Okay, that's fine.
Now, could we ask you, Dr. Kang, is there any plan to modify the vaccines that we create in the light of the variants that are developing?
That's already happened. So Moderna and Pfizer have made new vaccines based on the beta variant. These have been evaluated. And
But we are now bothered with the Delta Plus, isn't it? Or Delta
yeah,
at least.
so it's easy for them. For the mRNA vaccines, it's easy to make new vaccines. But I don't see why we would bother with a new vaccine for the Delta variant, because the antibodies that we are making in response to the earlier versions of vaccines seem to be protecting quite nicely against the Delta variant.
That is a very point to be emphasized, Dr. Kang, because our worry is, especially when we talk about the third wave and all that, will the vaccine that we have taken protect us at all? So are you saying that don't worry that way to protect?
Yes, I'm saying don't worry. The vaccines that we have, at least for the Covishield vaccine, we know that there is good protection against hospitalizations and other forms of severe disease with the Delta variant as well as with other variants. We've seen this in data from the UK. We've seen this in data from India. There is going to be much more data from India, which is going to come. And it is on the same positive lines as we have seen from the, the first effectiveness data was from CMC, but there will be much more of the same, showing that the vaccines are working. The problem for us, of course, is that we have effectiveness data, but we don't have sequencing data, unlike the UK. But we can infer that at this time, we have a lot of Delta variant around. And if the vaccines are working, they're working against that variant.
UK data, I think on the Delta, I think it's quite convincing. 2 doses.
Dr. Sujitra wants to know, is there a sex difference? Are the men or the women producing more antibodies to the vaccine or any difference?
Well, in terms of the responses, I think one of the things that's important to emphasize is that we choose our dose of vaccine carefully. We choose it to maximize the immune response to that particular vaccine that we are giving. Unlike infection, which can be variable, you don't know what the infectious dose is, you don't know what time you got it, you don't know how good or bad the response is. We actually don't know. We do know that asymptomatically infected people produce less antibodies than people who have symptoms or severe disease, right? Now, what determines who has asymptomatic infection and who doesn't? We don't know that, but we do know that vaccines are designed to overcome that barrier and produce a robust immune response in everybody who gets the vaccine. So there is still some heterogeneity in response, a fair amount of variation. But if we look at the data from the clinical trials, we know that 98+% of people make antibodies to the vaccines. Whereas for infection, it seems like only 70% of people who are asymptomatically infected make vaccines. So there's a lot more we need to learn.
Would you recommend the second dose to the pregnant women? Like now it was 1 month, now it is 84 days.
Yeah. So I think this was a question that was asked. Should you take Covaxin because then the gap is only 4 weeks? I think this is something that we are still learning. And yes, practically it makes more sense to have a vaccine that you can give after 4 weeks rather than have a 3-month gap between doses. I think the important thing is we should be vaccinating and documenting what we do, so that we can learn and then make more evidence-based decisions in the future.
Is there any fixed interval required from a vaccine and then an elective surgery to follow? Similarly, any interval from a elective surgery and then vaccination to follow? The interval required?
So let's think about why we would want to know this. We want to know this if the goal is to have protection from COVID during the surgery, then you need to wait till that immune response is mounted. But otherwise, your immune system is perfectly capable of handling a vaccine plus everything else that is thrown at it. The stress of surgery is going to have a minor implication on your ability to respond to a vaccine. So while I would not advise that you have the vaccine today and go for surgery tomorrow, in principle, the fact that you had a vaccine today does not mean that you cannot have a surgery tomorrow if you really need it.
Thank you, Dr. Kang. And one other point, we do in obstetrics get quite a few patients with thrombophilias. And you already earlier referred to those who are on immunosuppression. Is there any need of modifying your strategy depending on that? You earlier said no special testing is required, but if we know that somebody is thrombophilic.
No, there's no need to modify any strategy. As I mentioned, this is a completely idiosyncratic immune mechanism, just like with heparin-induced immune thrombocytopenia. We actually don't know who is going to have this side effect, and no prior condition predicts that you will have this side effect.
Thank you. That's quite reassuring.
Dr. Kang, I've got a question to you. Taking the vaccine, could you get a false positive RT-PCR?
No.
No.
Okay, so let's think about where do you take the vaccine and where do you sample for RT-PCR? You take the vaccine currently through injection, right? Injection at a localized site, usually into the muscle. If we are going to take DNA vaccines, we may have a subcut dose, but right now it's injection into the muscle. When we do PCR, we do PCRs in the nasopharynx or oropharynx. You're not going to have, even with an inactivated vaccine, you're not going to have that whole viral particle travel from the site of injection to the site of sampling.
I have a query to ask. Pregnancy, you have immunosuppression, you have so many physiological metabolic changes. Does pregnancy decrease the efficacy of the vaccine in some way?
So far, there is no evidence to indicate that that happens. I mentioned previously that there have been studies that have looked at immune responses to vaccination. and it does not appear that pregnancy impairs the immune response to vaccination.
Let me add a comment to in response to the earlier topic about some of the questions that we will get as doctors from our patients when they come in for vaccination is, doctor, what are the side effects? And the common side effects are that occur in the first couple of days after vaccination. Most of us, what we went through, but I want you to I'll just give you a summary of the study we did from Cochin. Myself, Ramesh Shenoy and Anita Devi, we did a study on 5,396 patients people who mostly healthcare workers who got, most of them got Covishield, 94% got Covishield, and their experience, I'll explain it here very briefly, and that will be helpful to explain to our patients. Out of this group, which is largely younger healthcare workers, 2/3 would get symptoms. So don't be surprised if we get symptoms. 2/3 would get symptoms. Women and younger people got symptoms more, and almost nobody had symptoms on the 3rd day. So most symptoms would occur about 9 hours, 8 hours after the first dose, and they may continue into day 2. Very few people got day 3. So this is a realistic experience that you can actually pass on to your patients. So that will reassure them greatly. And the second point that will come along with you, the second question most of them will ask you is, doctor, if I don't get these symptoms, does that mean that I'm not generating an immune response? Now, the answer to that is an absolute no. There's no relation between whatever symptoms you feel after your vaccination and the amount of immune response you generate. So that's helpful information for you.
Thank you, Rajeev. Sandeep, did you want to say something in between?
Yes, sir.
Yes,
So far, sir, can you hear me? Sir, so far,
we can.
45 cases of severe AEF, acute events following immunization, and about 145 serious cases were reported.
Can you repeat that? We could not follow that. Can you repeat?
Can you repeat that?
Yes, sir. Sir, we had a system of reporting the side effects, not side effects, actually events following immunization. So far, 145 serious cases and 45 severe cases are reported out of the 1,30,00,000 vaccination.
What are these main cases? Explain what those serious and what is their severe.
Yes, sir. Serious means something required for the hospital admission, and it includes any neurological deficit or severe anaphylaxis or something like that. But the serious reaction is that not that fever or mild myalgia and others following immunization is not that come under mild, and anything between the severe and mild is become serious. And usually there is a committee in the state level as well as the district level which will look into the individual cases of AEFI and decided whether it is related with immunization or it is a coincidental. And then also there is a state level committee which will usually discuss serious diseases or serious cases of AEFI.
Adverse events after the vaccination, that is what you are referring to by AE. Am I right?
AEFI, sir. Adverse events following immunization. I think along with for all vaccines, there is a system. So they categorize actually after reporting at the district level and at the state level, these are categorized into 5. First is product related. Second is product, which is actually the vaccine directly related to the vaccine. Then the technique of administration, then anxiety related, and finally, like there is a coincidence also. So this recategorization happens. So that happens with all, and I think when COVID vaccine was also introduced, the same system continued. The initial 30 minutes after vaccination, those side effects are entered through the COVID portal, and the remaining through the usual AEFI mechanism. So that is there for all childhood vaccines.
Was there any death as a result of a complication of vaccination?
Sandeep has gone.
Yeah, Sandeep has
Yes,
just moved away.
there are. I don't know about Kerala, but there are.
Others, I think all India data, I think Government of India published. Dr. Kang is going to explain.
Dr. Kang, was there any death related to the vaccination?
Yes, there is one death due to anaphylaxis that was causally related to vaccination. There have been other episodes of anaphylaxis also which were causally related, but the people who had these events survived. So and this is based on analysis of the first set of data from the government. There is a lot more that the National AEFI Committee also needs to investigate.
Sandeep, was there any death related to the vaccination in the state of Kerala, to your knowledge?
After investigation, no. Sandeep, can you hear us?
I think he is muted.
Sandeep is
Venu,
muted. Venu, can you?
Sandeep,
I asked him to
Sandeep,
unmute.
in the AFI, yes, Sandeep.
Yeah, I asked him to unmute. I think he's on another call.
Okay.
Sir,
Shall we move on?
actually, some of these, the AFI committee has multiple experts. Finally, some of these deaths might be categorized as coincident. For example, a myocardial event. But then the discussion point is that the investigation is for sometimes, I think very often autopsy is also performed in such cases. So there is a triangulation of data to prove that whether we can attribute that to the vaccine. For example, in the exam, I think it was from UP or so, that Anaphylaxis death. So they finally established that this is directly related. There is a causal relationship. Otherwise, many of these may be mere coincidence. I was about to ask Sandeep, I think Dr. Kang is here. At the national level, is there any decision to have an independent, just like what was happening in US, in India also, different data sets on antenatal women? Incidentally, to Lakshmi madam, you asked about, madam asked about the peri-conception thing. The US data that we were discussing includes the peri-conception, I think 30 days prior to LMP. That is the total data. It's not only people who have been pregnant, but then 30 days prior to the LMP. That is also there. The peri-conceptual period is also included in the data. Dr. Kang, do we have a similar mechanism? Are we planning for it, or it will be in the general?
Actually, what happens for pregnancy is that the manufacturers are expected to maintain a pregnancy registry for their vaccines. So in their, so once you have a product that goes into the market, for at least 3 years, they have to provide periodic safety update reports. And included in those PSURs is expected to be a pregnancy registry. This can also be asked for specifically by the regulator of the companies, and the companies then have to comply. All too often, they do it just by telling people that, yeah, you know, just sending out written instructions that people don't follow. So our data tends to be relatively poor in this area.
Shall we move on to the topic? Actually,
sir, just one thing, I think for our gynecologist colleagues, that question regarding, you know, elective surgeries, I think Rajeev sir would answer that. That, you know, for example, a hysterectomy, is there a patient already vaccinated? Ask whether, you know, how much time to proceed with hysterectomy, or after a hysterectomy, how much time to take a vaccine. So what I think
that was answered actually, Venu. Dr. Kang already answered.
Dr. Kang already took it. Dr. Venu, Dr.
Okay.
Kang already answered that. She said there's no,
if I could
you know,
just
obviously you don't
back,
want to do it the next day, but she said it's fine. It is fine if you give a little bit of a gap, it is fine. You don't have to wait a whole month. I think that is really what her message was. Is that right, Dr. Kang?
Yes, that's right. And I'm very sorry, but I thought this was for an hour. So I had asked someone to call me at 9 o'clock.
Shall we stop?
That's okay.
Dr. Kang, I've got just one last question to you. What have you got to say about the third wave? Do you think it's a speculation, or do you think it's real? Because I read somewhere that, you know, what Delhi observed recently was actually its fourth wave. So have you
That's
got any?
correct.
That's
Yeah,
correct?
no, Delhi was its fourth wave. And we have to understand that Delhi is a peculiar place. It's a place where there is a lot of movement in and out. And therefore, the number of susceptible people that you have changes over time. In other places where you have more stable populations, you're unlikely to see similar patterns, especially now. I wouldn't, you know, I think a third wave is extremely unlikely. unless we get a new variant, if we are expecting the wave to have the magnitude of the previous waves. However, will we continue to see upsurges in cases? Yes, we will, because we are not fully vaccinated, we are not fully infected, and India is a country with very large numbers. We shouldn't expect those numbers to decline to zero anytime soon. This is a virus that's respiratory. It will become seasonal if we don't make efforts. If we go the other end and we say we want zero COVID, which is what some people are thinking about, then that requires a humongous amount of effort. It's unlikely we will make that effort. So we will see surges, but not on the magnitude of what we saw previously. If there is a variant that is very, very infectious and very dangerous and escapes all vaccines, then of course, all bets are off, because then we are dealing with a completely new virus.
Can I just ask you, as the only person from outside Kerala in the faculty, we are really concerned. Why is that our TP are not coming down? Why is our infection rates not coming down in Kerala, where we were boasting in the beginning that we have it under our control? Our deaths
I think
now.
Your problem is honesty.
Yeah, that's exactly what I was about to say.
I think so. But anyway, do you have any other theories? Wanted to ask you.
No, I really think it's because Kerala is one of the few states in the country that is reporting well, that is following everything that is supposed to be done. Is there more that we could do? Yes, of course. There's always more that we can do. But I don't think that this is something Kerala should worry about. It's a densely populated state. Not everybody has been infected. What I'd like to see is a district level sero survey from every district in Kerala. Properly designed, properly done, that will identify then what are the potential pockets that we need to worry about cases, future cases in. Because where there is low seroprevalence, you have the opportunity for upsurges.
One other
I think
question.
in the last, just
one other
Dr.
question.
Kang, in the last zero survey, lowest was in Idukki, 5% and highest was in LFP, which is 14%. I think districts like Thrissur had just 8%, but it have all changed much. But then there's a high degree, and within districts also, I think the wave pattern, as you were mentioning, might be different actually.
So that's exactly why you need the zeros. Yeah, you need them.
One other point I wanted to bring in, Indu, you in the beginnings told us about the variants and the waves and probably another wave. The government of Kerala as well as government of India are gearing up, saying that the third wave is going to hit the pediatric age group more, and they are preparing for that. My worry is, doesn't it equally affect the potential for the pregnant women?
Dr. PAILY, can we let Dr. Kang go? I think she needs to leave.
Yeah, okay. Yeah, okay then. Thank you, Dr. Kang.
What is your final remark on the child? I think she was you were about to say something.
I have no biologically plausible reason to think that children will be affected any more than any other age group. We know that children are getting infected already. A small proportion is manifesting with disease, and that's as expected. That's the pattern. Children will get infected at the same rates as adults, may get a bit higher if children are not vaccinated and adults are, but the severity of symptoms, the proportion will remain exactly the same. So thank you very much. And
thank you, Dr. Kang, for spending time with us. And I know we're so grateful to you. Rajeev and Indu, if you could stay on a little more. Can you both?
Yes,
okay,
yes.
Dr. Kang, it was lovely having you.
Thank you. Yeah. Rajeev, if I could come back to you with the same question about this wave that is will or will not come, and whether if you feel that the pediatric age group, because they have not been vaccinated, are likely to be affected more, Same applies to the pregnant women, isn't it? Because they also have not been vaccinated.
Okay, how much time do we have? It's I want to tune my answer accordingly. That's why I can answer that in a minute
maybe,
or 10 minutes. That's why.
Venu, maybe
Yes,
another
sir.
5 minutes.
Let him tune
5
it
minutes?
like he likes it, sir.
Okay.
5 minutes is good. Is that?
You are a communicator, so you can decide how much.
I know, that's why I asked, because it depends. So it's 9:15 now. When do you want to stop?
Oh, by 9:30 we have to wind up. Yeah.
9:30. Okay, so we'll stop just before 9:30. So I'll speak for about 2 or 3 minutes on this, maybe a little longer, because it takes a bit of time to explain that, at least what I have in my mind. I'll take the question in 2 parts. And Indu, can you also pitch in between, all right? Or maybe after.
Sure, sure.
See, the first is about children. See, let's just go back in time and find out where this remark came from. This remark came from some doctors who made a statement saying that children are going to get affected in big numbers. So it's their opinion, but this opinion being scary, it was immediately picked up by all media, and I think it reached everyone in India and abroad. So I think what the doctor really meant was, the children are the least vaccinated group. As vaccination progresses, you're going to have more and more people. If you imagine a large cloud casting a shadow on Earth, you see the shadows growing, and the people who are outside the shadow are just the children. So naturally, if a wave hits, the children will be affected more. So theoretically, what the doctor said was right, but the way it was projected was completely wrong. So I'll come to the numbers now. It is true, if you look at the infection rates, new cases and deaths, you can see a gradual shift. Even in Europe, if you look at the data in Europe, you can see a gradual shift of the cloud shadow that I mentioned. Imagine the clouds coming over you. You can see that if you see Europe and India, you can see that more younger people, or maybe 10 to 15 years younger people, are going through what would have happened without vaccination. So that's one. Second is, as far as children go, why I don't, I can only say what I think. I don't believe they'll be affected in big numbers for 2 big reasons. One, at least in Mumbai, we have established zero survey that says that over 50% of children are already having antibodies. Now, when you say already having antibodies, I would add about 15% to that, because you can't pick up all the antibodies anyway, so they decline. So let's say 65%. So that's about 35% children. And plus a huge number of adults, which are their parents, are already infected. So who's going to give them the infection? And then you got a large number of people who are vaccinated, which again, if you have parents who are vaccinated, the chance of the parent giving the child COVID-19 is quite small. Now, what I do not know is what the impact of opening schools will be. At some point, our classrooms are going to come open, and I have no idea. And honestly, I don't believe in mathematical models, because many of them are wrong. So it's good to have models, but many of them are wrong. So we can't really rely on what they say. But I'll simply say I have no idea what opening of schools will do to India. I'll just leave that as an unknown, because I greatly respect an entity called the unknown. That's in the unknown box. Because as you know, the schools are like a circuit breaker. You open the circuit breaker, all the lights come on. If there is one virus in any house in supplying the school, it will come to the classroom, it will hang around the classroom for 6 hours, and it will go back to every house, because Delta variant runs fast. Children talk, children are physical. We are not Sweden or Britain. Our classrooms are crowded. Children are really physical. They make a lot of noise here, and virus will spread. As I'm hoping that the schools will open only after a substantial vaccination coverage is done. So that is my take on children. And the third wave, again, along the same principles. Kerala, 90% were vulnerable back in February. The Zero survey from ICMR, 90% were vulnerable at the end of February. Let's add 5% to that. Okay, 85% were vulnerable. As I said, some antibodies may be falsely negative. So at the end of second wave, I don't have any data, but it may be somewhere in the 50% range. There's a large number of people who've been either vaccinated or naturally infected. So if a third wave comes, it may not really have. It's like a wildfire can only burn the trees that are dry in a forest. If there are many dry trees in the forest, and there's plenty of wind, the fire will sweep through the forest. But if there are no dried shrubbery in the forest, the wildfire might not go very fast. So I think Kerala took a severe hit partly because we didn't have that many immunized individuals. Immunized in the sense, naturally immunized individuals. So personally, those are my arguments for saying there will be third, fourth, fifth waves, etc., whatever you call it. But Kerala, for your information, has already had, we are on the fourth wave now. We had 2 waves last year. From IMA Cochin, we had declared the third wave back in January. It hit the national media. We had recorded a 70% filling of our ICU beds here in Ernakulam district. And that sent an alarm to the government, and the government responded, and the measures contained the wave. And then the wave came down, and then the elections came, and all hell broke loose. So we are, in fact, in Kerala, we are sitting on the fourth wave. So the so-called third wave, in simplistic terms, it is good to educate the Aam Aadmi who may not really have a great idea about epidemiology. And also it will reassure them, or at least it will educate them, that once the lockdown ends, all will be well. There's a large number of people who believe that once the lockdown ends, everything will be fine. There'll be no virus. I think that really caught India on the wrong foot. And I think this concept of third wave, in one sense, it's good. So those are my comments. Thank you.
Thank you. Indu, do you want to add any comments to that?
Yes, I'll just speak the data, because I'll take one example of Trivandrum district. 10 to 39, the overall pattern, or the overall, all over, I think from first case till now, 47% was in 30 to 49 years, 40 to 59 was 31%, 60 to 69, 10%, 70 plus is 6%, and below 10 years is 6%. If we take the first wave also, the pattern is similar. If we take the second wave also, the pattern is similar. But that 6% of under 10 years, 60% of our cases happen during the so-called second or third wave, the April end to June middle, this time. So naturally, 6% of those numbers became a huge number. Though the severity, the proportion of severity among children was very trivial, you see 0.01% of a few hundreds became a larger number. That is why we have MISC children admitted. So it's not that the virus is, has a severe infection among children or the youth, but then among the youth also, right? If we look at the mortality numbers, the number of people who died in the 40 to 50 year age, all that have gone up. That's also because, elderly were vaccinated in this. And regarding the wave, as everyone knows, it's Kerala had a very plateaued of it was there. That was a point of discussion in my previous slide. So it's plateauing off. Second wave also, though from October and all, we had but then it was never a steep rise and a steep fall, because our surveillance system is good. So it's good to have numbers, because it's good to have testing. It's good to have a surveillance system in place and identify cases, so that we see lockdowns come because the number of cases go beyond our systems capabilities. നമ്മുടെ ആശുപത്രിയിലെ കിടക്കയെ കഴിയും കൂടുതൽ പേഷ്യൻസ് വരും. അതുകൊണ്ടാണ് പിന്നെ ലോക്ക്ഡൌൺ വരും. അതുകൊണ്ട് നമ്മൾ മോണിറ്റർ ചെയ്യുക എന്നുള്ളതാണ്. So I think vaccine is going to protect us. Delta wave, all these UK studies, which Ireland, several other, because Delta is now in 96 countries. So there is a lot of AstraZeneca data coming up, though we don't have much of a Covishield data on Delta. Because genomic sequencing also has to happen in parallel in large numbers if we have to see efficacy of Covishield among Delta, in Delta. But then Astra is enough. So 2 doses is really protected against severity. നമുക്കിപ്പോ അസുഖം വരുന്നല്ലോ കാര്യം. നമുക്ക് നമ്മുടെ ഗർഭിണികൾ ആശുപത്രി കിടക്കരുത്, IC യൂണിറ്റിൽ പോകരുത്, മരിക്കരുത് എന്നുള്ളതാണ് പ്രശ്നം. അതിന് വാക്സിനാണ്. കാരണം അത് ഡെൽറ്റ ആണെങ്കിൽ പോലും, കേരളത്തിലെ ഡെൽറ്റ ഉണ്ട്, നമുക്ക് നവംബർ തൊട്ട് IGAB-യിൽ റെഗുലർ സർവൈലൻസ് ഉണ്ട്. ദാറ്റ്സ് ഓൾസോ ഇമ്പോർട്ടന്റ് ടു പിക്ക് അപ്പ് വേവ്സ്. അപ്പം അത് നമുക്ക് ഉണ്ട്, ഡെൽറ്റ നമ്മുടെ കയ്യിലുണ്ട്. ഇപ്പൊ ഈ വേവിൽ അല്ലെങ്കിൽ നമുക്ക് ഇപ്പൊ ഏപ്രിൽ മെയ് മാസങ്ങളിൽ സിവിയറിറ്റി കൂടുതലാണ്, ഡെൽറ്റയ്ക്ക് സിവിയറിറ്റി കൂടുതലാണ്. അതിന് സിംഗപ്പൂർ ഡേറ്റയുണ്ട്, ജപ്പാൻ ഡേറ്റയുണ്ട്. അതിന്റെ RT ഈ ടൈപ്പ് എക്ക് ആൽഫയ്ക്ക് 1.5 ആണെങ്കിൽ ഡെൽറ്റയ്ക്ക് 1.8 ആണ്. ഇൻസ്റ്റന്റേനിയസ് റിപ്രൊഡക്ഷൻ നമ്പർ എന്ന് ഒരു പോയിന്റ് ഓഫ് ടൈമിൽ എത്ര പേര്, അതൊക്കെ ഡെൽറ്റയ്ക്ക് കൂടുതലാണ്. ദർ ഇസ് എ ലോട്ട് ഓഫ് എവിഡൻസ്. ദാറ്റ്സ് വൈ ഇറ്റ്സ് സ്പ്രെഡിങ്. റഷ്യയിലും നമ്മൾ എല്ലാ രാജ്യങ്ങളിലും കാണും, ഓസ്ട്രേലിയ, പല സ്ഥലങ്ങളിലും അവർ കൂടുതൽ റെസ്ട്രിക്ഷൻസിന് പോകുന്നത് അതുകൊണ്ടാണ്. സോ ഡെൽറ്റ ഹാസ്
ഡെൽറ്റ പ്ലസ്, people talk about ഡെൽറ്റ പ്ലസ്.
ഡെൽറ്റ പ്ലസ് എന്നുള്ളത് ഡെൽറ്റയില് ഈ ബീറ്റയുടെ പോലെ സിമിലർ ആയിട്ടുള്ള ഒരു AY1 ചേഞ്ച് ആണ്. ബീറ്റയുടെ പ്രശ്നം ഈ സൗത്ത് ആഫ്രിക്ക, നമ്മുടെ എല്ലാ വാക്സിൻ ട്രയലുകളുടെയും, നമ്മുടെ ആസ്ട്രാസെനിക്ക ഉൾപ്പെടെ സൗത്ത് ആഫ്രിക്കൻ ആമിൽ എഫിക്കസി കുറവാണ്. ഇത് ഇപ്പോഴല്ല, കഴിഞ്ഞ വർഷം നമ്മളെ നവംബറിലെ ഈ സ്റ്റഡി റിസൾട്ട്സ് വന്നപ്പോൾ ഡിസംബറിലെ നമുക്കറിയാവുന്ന കാര്യം. അത് ഈ ബീറ്റ വേരിയന്റുമായിട്ട് റിലേറ്റഡ് ആയതുകൊണ്ട് വാക്സിൻ എഫിക്കസി ഡെൽറ്റ പ്ലസിന് കുറയുമോ എന്നുള്ള ഒരു സംശയമാണ് സർ ഉള്ളത്. പക്ഷെ ഇപ്പോഴും ഈ ഡെൽറ്റ പ്ലസിൽ ഇത് എങ്ങനെയാണ് വാക്സിൻ എഫിക്കസി എന്ന് അറിഞ്ഞുകൂടാ. എന്ന് മാത്രമല്ല, ബീറ്റയ്ക്കെതിരെ ഐ തിങ്ക് ഓക്സ്ഫോർഡ് ഓൾസോ ഹാവ് സ്റ്റാർട്ടഡ് ദെയർ ട്രയൽ. Pfizer has also developed. So it's a different vaccine. അതിന്റെ കുറെ ബേസ് അങ്ങനത്തെ കാര്യങ്ങളെല്ലാം നമ്മുടെ ഇപ്പോൾ എടുക്കുന്ന വാക്സിൻ പോലെയാണ്. പക്ഷെ ബീറ്റ എന്നുള്ള വേരിയന്റിന് എഗൻസ്റ്റ് ആയിട്ടുള്ള വാക്സിൻ കൂടി അതിന്റെ ട്രയൽ എനിക്ക് തോന്നുന്നു ഈ സൺഡേ തുടങ്ങി. അപ്പൊ അത് വരും സർ. അപ്പൊ അങ്ങനെ വേണ്ടി വരുന്ന ഒരു സമയമാണെങ്കിൽ വരും. ബട്ട് ആസ് സച്ച് സം ഓഫ് ദോസ് നേച്ചർ സ്റ്റഡീസ്, ഇപ്പൊ നേരത്തെ രാജീവ് പറഞ്ഞല്ലോ, നമ്മൾ ആന്റിബോഡി നോക്കിയാണോ ഇതാണ്. ആന്റിബോഡി മാത്രമല്ല, ലോങ് ടേം ആയിട്ട് നമ്മൾ എടുക്കുന്ന വാക്സിൻ, നമ്മൾ DTPയും TD ഒക്കെ നേരത്തെ അല്ലേ കുഞ്ഞുങ്ങൾക്ക് കൊടുക്കുന്നത്. അവർ എത്രയോ നാൾ അതിന്റെ എഫിക്കസി വരുന്നത്. നമ്മൾ ബൂസ്റ്റേഴ്സ് കൊടുക്കുമ്പോൾ അത് പെട്ടെന്ന് കൂടും. അപ്പൊ ഈ ബോൺ മാരോയില് പ്ലാസ്മ സെൽസ് ഇങ്ങനെയൊക്കെ വെച്ചിട്ടാണ് ഇമ്മ്യൂണോളജിക്ക് മെമ്മറി. അപ്പൊ കുറെ വർഷം കഴിഞ്ഞ് അപ്പൊ അത് മറ്റ് ഇപ്പൊ ഡിഫ്തീരിയയ്ക്കൊക്കെ എങ്ങനെയാണോ വരുന്നത് അതിന്റെ സിമിലർ ലൈൻസിൽ തന്നെയാണ് ഇപ്പൊ ഈ ബോൺ മാരോ സ്റ്റഡീസ് ഒക്കെ കാണിക്കുന്നത്. ബോൺ മാരോ പ്ലാസ്മ സെൽസ് ഉണ്ട്. ദാറ്റ് ഷോസ് immunologic memory will be there. So those are all positive. I think it's not much of a concern now, except the beta issue ആണ് ഉള്ളത്. അതിന്റെ ഡേറ്റ വന്നിട്ടില്ല. We are waiting for that. Apart from that, delta, നമുക്ക് ഈ ഡെൽറ്റ പ്ലസ് കേരളത്തിൽ അങ്ങനെ പടരുന്നില്ല, കുറച്ചേ ഉള്ളൂ. പിന്നെ നമ്മുടെ സർവൈലൻസും എനിക്ക് തോന്നുന്നു നമുക്ക് ഇപ്പൊ ഇന്ത്യ മുഴുവൻ ഈ ഡെൽറ്റ പ്ലസിനെ ട്രാക്ക് ചെയ്യാനൊക്കെ നമുക്ക് പാടാണ്. UK ചെയ്യുന്ന പോലെ ഈ ജീനോമിക് സീക്വൻസിങ് നമുക്ക് വലിയൊരു നടപടിക്രമമാണല്ലോ. ഇത് അയച്ച് every other lab cannot do that. Our facilities are limited. So that may be the reason. But normally Delta mail kandupidicholu allengil announce cheytolu. Probably it was there earlier itself.
There's a question from Dr. KAUSHIK, that is from UNICEF. Given the demand-supply imbalance, what's a better vaccine strategy on balance? Vaccinate as many as possible with first dose, or to vaccinate priority or vulnerable groups with 2 doses? Both Indu and Rajeev can briefly address that.
Yeah, I'll take that. See, the problem is these are questions that don't have definite answers right now. We just don't have the data to back up. It's mostly opinion-based advice here. So that's the answer to that question. If we ask 10 people who really have studied the subject, 5 will have one opinion and 5 will have the others. But I'll add one more aspect to vaccination here. See, vaccination is it's a 3-dimensional topic. We have very simplistic views. See, we heard about the low efficacy in South Africa. You know what they measured? They measured symptomatic disease. They didn't really have the sample size to even start measuring severe cases. So what are we talking about? See, they didn't have enough severe disease to start with. But when we see these numbers being repeated over and over again, 30% efficacy, that's nonsense. If you haven't even measured, if you study 1,200, 1,500 patients, participants, what are you going to come up with the efficacy? So I think there are some other non-scientific reasons as well for AstraZeneca to be kicked out of South Africa. I'm not going to get into that. That's just speculative, but I can tell you, don't go by the South Africa trial. There's something profoundly wrong with it. That's just what I've analyzed practically every paper that's come out. So one more point is, this is a practical aspect point, which I'll mention to all of us who are healthcare workers, primarily in this audience. See, a vaccine will work only if the people around you are also vaccinated. And that's an important concept. See, if the people around you are not vaccinated, there's a good chance one of them might give you the infection. So keep that in mind as healthcare workers. So encourage your team members to get vaccinated. You might wonder, what's the problem? There's a glass ceiling for vaccination. No matter what country you're in, you're not going to go beyond 70%. Trust me. Kerala, I don't know what the official percentage is, but I don't think, let's say 90%. In healthcare workers, there is a good number of people who are anti-vax or very anxious against vaccines. So you're gonna have a lot of people around you.
Can you unmute Dr. Sandeep?
So that's something I'll leave you with. Just keep that in mind. All right.
Sir,
Yes, Sandeep.
Sir, presently there is 32% got the first vaccination.
Say it again, Dr. Sandeep. Sorry.
Total population or?
Total population.
32%, Rajeev.
32% as per the 2011 census. The projected population comes around 31.5%.
Okay.
And a full vaccination is 9.5%.
Okay. That's
And
very
also
good.
that
Very good.
the doubt means that the total, that is about the COVID vaccination. Our previous experience, the routine vaccination, that is UAP, Universal Immunization Program, it will be around 90%.
90?
90.
Yeah.
That is even with a very great effort. Otherwise, that the previous year it has come down to 82%.
But the problem with COVID
yeah.
is it's such a sensational topic, and you hear all these stories about young people dying and countries banning vaccines, and there's a good number of people who are sitting out there wanting not to be vaccinated, and that includes my close friends as well who are doctors. So don't underestimate the anti-vaccine capacity of the world population. So,
Yes.
but unfortunately, in the end, it is the others who will suffer, because for their folly, they're going to infect their colleagues. So keep that in mind as we practice.
Indu, any last word you want to? I think Indu is muted. Yeah. Okay. Venu?
I think vaccination is the answer. I think lots of questions will come. So it's important that, as Sangeeta or many others pointed, it's important that we have a common write-up on the FAQs with antenatal vaccination. Lots of, because we have to speak science. We cannot. It's a logistics issue. So people will ask, is Pfizer superior and all? But we have to tell them the facts. See, Astra, what is efficacy? See, and what about in relation to this question, this particular question, 2 doses of Oxford vaccine, that we have real life data from UK, Ireland, and many other countries which give AstraZeneca vaccine. So 2 doses of vaccine is effective. Not only, it depends on the primary outcome, as Rajeev was pointing out. If our primary outcome is just infection, a disease, or is it severity, is it hospitalization? So in relation to Delta, we have solid data from many countries that hospitalization, if that is the outcome, if severity is the outcome, if death is the outcome, the efficacy of Astra is very high. It's very good. Pfizer is very good. But in all this, it is slightly less than the mutation part. If it is 90%, 95%, it has come down. But then it protects against severe infection. So our concern is that our women, antenatal women should have a safe journey. That way it really protects. I think 2 doses is enough. With the available data, if we go by the data from AstraZeneca, 2 doses protects against these, against Delta. But otherwise, in general, I think a single dose efficacy, Rajeev was mentioning, but I think for Delta, the current data shows 2 doses is sufficient. That's why.
Thank you, Indu. I think it's time for us to wind up. Officially, the thank you will come from Venu, but there is a silent rapporteur we had who has to come on the screen. Sangeeta, are you there? Monitoring whatever has been discussed and presented. Sangeeta Menon from Trivandrum.
Yes,
has been monitoring whatever has been doing. We have been talking about. So hopefully we will get a summary of the events and discussions later on from Sangeeta. Thank you, Sangeeta, for keeping close watch. Venu, your turn.
Thank you very much, sir. And at the end of it, I think it's a nice way to finish off the month with this very useful activity. And how it came about is, as usual in our KFOG, I think our president, Ajith sir, he on Sunday, I think it's a very shortly convened meeting. On this Sunday evening, it was when he suddenly suggested, always it's on his mind that we should do something for our members. So he said, Venu, namkona vaccine highlight. I think the next halt for all this is PAILY sir, from Ajit sir and PAILY sir. Thank you very much. You have assembled such a wonderful faculty. I wish to thank Gagandeep madam. I think her presence was so reassuring. Dr. Rajeev, such an efficient and such an effective communicator. I think we learned a lot from your presence. Same to Dr. Indu. Thank you very much. You are in our program for the first time, I think so. Thank you, madam, very much. And of course, Dr. Sandeep, in spite of all his busy schedule, I think he has made it a point to come. And his presence here adds a lot of importance because he's from the government side. Thank you, sir, Sandeep, sir, very much. And of course, SAREENA ma'am, LEKSHMIAMMAL madam, and JYOTHI madam. All the questions, I think they have compiled all the questions, and they made all these question answer session made the discussion so much meaningful. I think Kaushik sir is becoming part of our team, and it was nice to see him ask a few questions also today. Kaushik sir, thank you very much, and we look forward to a prolonged, extended association with you. Thank you for all the help. To all the participants of this particular meeting, I hope that you have all benefited from the evening that you have spent the last couple of hours with us, and all our programs are meant for that only. They are meant for all our community and members, and I hope that this meeting served its purpose. For those who could not log in today, I think we will be putting it on the proceedings on our YouTube channel, and Kaushik sir, I think we'll put it up so that all our members, and it's a discussion will be useful for all. And I think Indu madam's suggestion of having a FAQs, I think our team will be in the act. And as always, PAILY sir, we'll be summarizing the proceedings for our members. Once again, a big thanks to all, especially Ajith sir for all the encouragement, and PAILY sir, again Kaushik sir, all faculty, moderators, and all who attended. Very good evening to all of you until we meet next time. Thank you very much for having logged.
Thank you, everyone.
Thank you, Venu.
Thank you.
all.
Thank you. Thank you.
Thank you, sir. Thank you, Lakshmi ma'am.
Thank you. Thank you and good night.
Thank you. Thank you. Good night.